Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and comments on the JCO article New Persistent Opioid Use Among Cancer Patients After Curative Intent Surgery by Lee et al. My name is Eduardo Brera, and I am the chair of the Department of Palliative Rehabilitation and Integrative Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas, USA. My oncologic specialty is supportive and palliative care. In this retrospective cohort study, the author's main objective was to define the risk of new persistent opioid use among cancer patients who received curative intent surgery. The authors identified from large insurance claim databases patients who were previously opioid naive, defined as having received no opioid prescriptions for at least 12 months before the surgery. And they defined new persistent opioid use as receiving at least one additional opioid prescription between 90 and 180 days after the surgery. In all cases, patients received a preoperative or immediate postoperative opioid analgesic prescription. Among more than 68,000 patients undergoing curative intent surgery, 60% were opioid naive. Of these almost 40,000 patients, a total of a bit more than 4,000, or 10%, became new persistent opioid users. The frequency of persistent opioid use was higher among patients who received adjuvant or neoadjuvant chemotherapy. The use of opioids in this group of patients not only persistent with regards to duration of use for a period of 1 year, but also with regards to dose that remained consistently stable at approximately 30 milligrams per day of hydrocodone. That would be approximately 45 milligrams of morphine equivalent dose per day. This study is important because the authors reviewed a very large patient population, and they were able to obtain data for a period of 1 year after surgery. The finding of 10% new persistent opioid users is concerning. However, due to the database nature of the study, several issues remain unanswered. Some patients may have developed surgery or chemotherapy-related long-term complications that might result in chronic pain. However, the majority of these patients would be eligible for treatments other than opioids. It is also possible that at least some of these patients had some level of persistent or recurrent cancer requiring opioid therapy. Due to the nature of the study, the authors were not able to determine clinical and/or socio-demographic characteristics that might increase the risk of becoming a persistent opioid user. The overall risk of substance use disorders, including alcohol and/or drugs in the general adult population in the United States, is a bit less than 10%. However, studies conducted by our group and others show that the risk among cancer patients is between 15 and 20%. And at least partially, this is related to the fact that alcohol is a risk factor for aberrant opioid use, and it is also associated with a higher frequency of many cancers. Among patients having successfully completed chemoradiation for head and neck cancer with curative intent, approximately 63% of patients continued on opioids for 3 months, and 33% of patients continued on opioids for 6 months after the completion of the radiation therapy. The frequency of risk factors for alcohol and/or drug, such as Gage questionnaire, was approximately 41% among patients who did not stop opioids, as compared to 12% among patients who were able to stop opioids. A number of studies have demonstrated that very brief self-reported questionnaires successfully identified patients at a higher risk for chemical coping with opioids. In view of the findings of this study and several others, it is important to regularly screen patients before prescribing strong opioids for the management of present or anticipated pain syndromes. It is important to recognize that opioids remain the most effective treatment for the management of postoperative and mucositis-related pain. The majority of patients undergoing these procedures, as well as patients who develop cancer-related pain, will require prescriptions for opioid analgesics. However, patients who are within the high-risk category should be monitored much closely with more frequent visits and smaller prescription quantities as compared to those who present no risk factors. Clinical studies have shown that patients who are current or previous smokers, patients with a history of alcoholism, patients with a history of psychiatric disease, younger patients, and male patients are at a higher risk of developing aberrant opioid use. This term reflects behaviors strongly suggestive of a development of substance use disorder, such as frequently reporting medication as lost, obtaining opioids from multiple providers, self-increasing in the dose of opioids, sharing opioids with acquaintances, requesting specific type of opioids, especially short-acting formulations, and having abnormal results in urinary drug screenings. It is important to consider early referral to supportive and palliative care programs or pain programs for patients who are at high risk. It is important also to notice that patients who have no apparent risk can also occasionally develop aberrant opioid use behaviors, and those patients will also require specialized care. The management of these patients is complex and time-consuming, and it frequently requires multiple visits to an interdisciplinary team, regular checking of the state databases before prescription, and the use of urinary drug screen, as well as pill counting to monitor adherence to the pain management regime. Ultimately, the main objective in the case of patients who have no clear evidence of pain after having successfully completed surgical or chemoradiation treatment is to discontinue opioids and most other psychoactive drugs and to allow patients to express their maximal physical and psychosocial potential for as long as possible. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.